from the Philippine College of Radiology and the Ultrasound Society of the Philippines. Okay, so earlier we were talking about interventional and of course advanced liver transplant. We're going back now a bit to more basic things, and it'll be liver elastography and liver fat quantification using ultrasound. And at this level, actually it is like we should go back earlier so that hopefully if we can monitor our patients, then we might not need the liver transplant. So when we say quantitative liver ultrasound, that means we're going to be talking about ultrasound-based elastography, which is like shear wave elastography, and we'll also be talking about liver fat quantification. So shear wave elastography has gained an important role in the diagnosis and management of patients with chronic liver disease. Liver stiffness assessment with shear wave elastography is now used for the non-invasive staging of liver fibrosis. And it's already considered to be a mature technique for the evaluation of chronic liver disease. So aside from liver elastography, we also have now new ultrasound-based biomarkers, and that is for quantification of liver fat content. And this is because they said that there's now steatotic liver disease epidemic. If you would like to know more about it, for those people who'd be interested in liver elastography, you can go over this World Federation of Ultrasound Medicine and Biology guidelines, and they have the updates on liver ultrasound elastography, as well as guidance on liver fat quantification. And you can also, and we also use the Society of Radiologists Ultrasound Liver Elastography Consensus. There's also a European version. Okay, so when do we request for liver elastography? And we want to know liver stiffness, and usually the reasons why we do liver elastography is for alcoholic use disorders, viral and autoimmune hepatitis, and non-alcoholic fatty liver disease. And why? Because this leads to advanced liver fibrosis, liver cirrhosis, and hepatocellular CA, where a transplant would be needed. Okay, so why do we need to stage liver fibrosis? And the importance is we need to determine prognosis. It's for surveillance, it's for prioritization of treatment, and to determine potential for reversibility. Actually, the reason why we're more concerned now with the liver fibrosis thing is because it is said to be reversible, and maybe if we promote this, then we can help the reversibility factor before people go to cirrhosis. So when do we request for liver fat quantification? And we also request for liver fat quantification still because we're thinking of non-alcoholic fatty liver disease, wherein it would lead to advanced liver fibrosis, liver cirrhosis, and hepatocellular CA. And maybe to doctor, maybe hopefully ultrasound will also be useful for the fat quantification. It is said to be similar already to MR-PDFF. So I'm going to just show you some terminologies. So when we say multiparametric ultrasound, it's using conventional ultrasound, elastography, contrast-enhanced ultrasound together with endoscopic ultrasound to provide comprehensive assessment of liver health. The main word we usually need to know is stiffness, because stiffness depicts on how hard or soft the area of tissue is. And then the other word is compensated advanced chronic liver disease. We need this in our diagnosis part later. So patients with severe fibrosis or liver cirrhosis who are asymptomatic. And those who have clinically significant portal hypertension are those with liver cirrhosis who are symptomatic. So how do we check for it? So by ultrasound, we can use ultrasound-based elastography. In the initial years, we had strain elastography, but now we have the development of shear wave elastography. Shear wave elastography can be divided into transient elastography or fibroscan and acoustic radiation force impulse or RFI. And RFI by itself can be divided to point shear wave elastography and 2D shear wave elastography. So there are liver elastography technologies. So if you remember, of course, we started off with B mode for anatomy, then we have Doppler for vascular, and elastography for mechanical stiffness. So when we say, what do we mean by, what's the use of elastography? So you see this white circle, that is the soft, let's say, object, and the black is the hard object. And when we do compression, then there will be more deformation of the soft object, right? So you can see that it will be more flat compared to the black one. In the same way, this is still the same. Hard tissues have less deformation, while soft tissues have more deformation. When we say hard, we're thinking of something malignant. When we say soft, we're thinking of something more benign. Okay, so we used to, I mentioned strain elastography, but strain elastography uses manual compression. This is now the technology that we're using. Acoustic radiation force impulse, it's just, there is now a special ultrasound pulse, and it's called the push pulse. You don't need to press the transducer anymore. It will just be the pulse that will do the work. So this is what we mentioned earlier. So again, I'll just mention, strain was a manual form, and it is used to deform tissue. However, now we do not use this anymore for liver evaluation. And I think this one is more familiar to you, vibration control transient elastography, which is fibroscan. This came before RFI came, and so it uses an external mechanical push to the skin by means of controlled vibration that generates shear wave. So they just put a probe, and then they put it at the side of the liver area, but actually we cannot see the liver. So there's no, it's sort of a blind process, but you're just putting it in the area of the liver. And this is most widely used and validated for fibrosis and steatosis quantification, and it's a point-of-care process. And I think the gastroenterologists have been using this for several years. But however, we must be reminded that we do not see the liver by itself, so it may be that it's semi-blind or blind, and we cannot choose the ROI, and the other limitations is obesity and ascites. I just mentioned this because for the recommended protocols, fibroscan actually has difficulty with obese patients more than 30 kilograms per meter squared. So now we are going to talk about acoustic radiation force impulse. So this is how the impulse goes. As I said, I won't go too much into the details of this physics because we've got such a short time. Anyway, this has been available. If FibroScan had been there for more than 25 years, RFI has also been here for almost 15 years with a large body of temperature. But our problem is, are there enough radiologists who perform RFI? And is this made available to the community? So actually, I wasn't able to mention that actually it's also giving back, because actually I trained my elastography, liver elastography and breast elastography in India. So in Hyderabad with Dr. Mateen, and Bangalore with Dr. Sudhakar. So I know, therefore, that you've been doing that for a long time. In the Philippines, actually, so I did it since 2018, but we added liver elastography only in 2023. Okay. So, as we mentioned, RFI has two kinds, point shear wave and 2D shear wave. So strain looks like this for the first, and point shear wave uses that little box, and 2D shear wave is a combination of qualitative and quantitative measurements. So for both point shear wave and 2D shear wave, they have different techniques, but their advantages is similar because we now use ultrasound. And because we use ultrasound, then we can actually see the area that we are interested in. Okay, so when we're looking at that area, this is the area that I'm looking at, and I'm going to measure this area. So supposedly, it should have less problems. Okay, so that's the area, for example, that little square for the point shear wave. And in that little square, we have one number. And then this false positive occurs for all, for FibroScan, for point shear wave, and also for 2D shear wave. So, but 2D shear wave appears like this. So although 2D shear wave and point shear wave may have similar results, and good results, but maybe 2D shear wave might have a bit difficulty in performing it, and the point shear wave it's so easy to do. But of course, everybody learns, right? So why do we now say that the clinical advantage of RFI compared to FibroScan? So it is because RFI now uses ultrasound, and we can see the areas, and we have lower rates of unreliable measurements and allow accurate measurement of obese patients and simultaneous stiffness and steatosis. Okay, so here's the recommended protocol, which I'll just go through because it's easy for you to remember anyway. You have to fast for at least 4 hours, rest for at least 10 minutes. It should be supine or slightly left lateral. You should put your arm raised up and put ample gel. And then when you do the transducer, should be perpendicular to skin and maintain adequate contact. And you measure with intercostal approach, and this usually reaches segment 5 and 8. And when you measure at the neutral breath hold, meaning you just tell them, okay, hold your breath. So when you say stop breathing, then you just say hold your breath. Okay? So they don't take a deep breath nor they move. And then the measurement should be taken 1.5 to 2 cm below liver capsule to avoid reverberation artifact. And the area should be 4 to 4.5 cm from transducer. And if you go down to 6 to 7, more likely you wouldn't have good results. So these are the conditions that affect fibrosis, obesity, ascites, Liver inflammation like an SGPT, which is 5 times higher. Liver congestion, extrahepatic cholestasis, severe alcohol. So if you have severe alcohol, you perform RFE 2 weeks later. And even food intake. So that's why we need fasting. So here are some of the recommended protocols. You should have a good B mode. You shouldn't be in areas with shadowing. You should stay away from the ribs. You should be 2 cm below the liver capsule. And then stay away from the vessels. Avoid shadowing. And stay away also from the gallbladder and blurry images. So you place the ROIs, avoiding large vessels and bile ducts and masses. And if you get the XXX, that means you didn't get a good value, so you just have to repeat it. Now, when we do the liver stiffness, you get, for FibroScan, you get 10 acquisitions. For point shear wave, you also get around 10 acquisitions. And for 2D shear waves, you get about 5. They say you can get lower numbers, but that's if you're good already. If you're not yet so good, so start with 10 measurements for point shear wave and 5 measurements for 2D shear wave. And the important numbers are the median value and the IQR median. Because, so when we get the IQR median is, if you have a KPA, we're using KPA, the IQR median should be less than 30, and for meter per second, it should be less than 0.15, less than 15. Okay, and if you see this, I don't know if you can see the IQR median part, so it should not be, it should be less than 0.15 for meters per second, and 0.3 for KPA. And that means you have a good number. So again, here are some, we use shear wave. So these are some of the examples. Philips used this, Mindray. And for point shear wave, you have Philips, Fuji, Siemens. Okay, this is an example. You have 0.82, that's normal. 1.5, starting to have fibrosis, and this is cirrhosis. I'm just going to mention the auto point shear wave of Siemens because usually we get 1 number. When we do this, this is a new technology. So when you get that, you get 50 numbers. So even if you take out so many outliers, you will still have many, many, many measurements. And then together with a point shear wave where you get 50 numbers, you can do the fat fraction at the same time. So this is the newer. They say the newer. Actually, that's the reason we got their new machine, because it was so easy to do. And I said, okay, I can do more. I don't have any more to reschedule it for a special occasion. But as I understand from Dr. Karki, he said, this is not here yet. So, but of course, the other suppliers also have their new technologies to show. So just for interpreting, we can use the update for the Society of Radiologists. And as I mentioned, these we have to include in the report. In these settings, the stage of liver fibrosis may be overestimated. That is in case you have this before you did the procedure. Okay, and again, that's IQR median. Now, when we interpret, we have to use the vendor neutral rule of 4. And what does that mean? So this is given already in the articles that I showed you. So they say 5, and then 6, 7, 8, 9 KPA, then 10, 11, 12, 13, and then 13, 14, 15, 16, 17. So that's 5, 9, 13, 17. 5, less than 5 meaning normal. 9, we put this one. In the absence of other known clinical signs, rules out compensated advanced chronic liver disease. And if these, further testing may be needed. And if we're already in 13, that means you're already ruling in compensated advanced chronic liver disease. And if you're in 17, that means you already have cirrhosis. So I just put this one. Actually, I made this graph based on what I learned from before in India. And then I put, this is the equivalent, and these are the numbers that were given by the new vendor-neutral rule of 4. So the answer is here. So whatever number we have, we give this on the side. Okay? And so for follow-up, sometimes they say, it's also important for the delta change, meaning your own values, and then what's your next value? So you compare to yourself. Okay, a person becomes his own or control. And then, if possible, it would be better you use the same equipment or a similar equipment, because sometimes the vendors have some difference in presenting their numbers. So for reporting, so this is also in that article. So you put liver stiffness measurements were obtained on, so you say your vendor and the machine and the probe, and how many numbers you got. So before I could say 10. So sometimes you make 15 and take out 5. So now I have 15 at one time. And anyway, I'm going to get another 5 for the fat quantification. So actually I have 60 numbers. So even if I take out many of the outliers, as I said, the median would still be good. And then, so you say whether you're using point shear wave or 2D shear wave. You mention your IQR median, because you're going to tell us if your data quality is good or not. Then you'd say the median liver stiffness, that's the number where we base our diagnosis. And then you follow now the rule of 4. And as I said, if in case you have those confounding factors, just mention them, that they may increase the liver fibrosis stage. This is how it's written there. Okay? So these are just some of the numbers that I said. So for Siemens and Philips, they have this similar number. GE has a high number, so they made their range a bit bigger. So this is directly to F2. While the F1.3, 1.3 here is more or less like mild to moderate. And then also, this is a FibroScan value. Okay, again, I just mentioned that. That's the same. So whatever number you got during your ultrasound, so if you say, I got a 1.7, then I'm going to say there's moderate fibrosis, suggestive of compensated advanced chronic liver disease, but need further testing. But if I already get a 1.7, then you now mention, a 2.1, then you can say liver cirrhosis. So now I'm going to have a little time to talk about liver fat. But I don't know if liver fat quantification is here now, but since we had the mind ray early yesterday, right? So more likely that has already the liver fat quantification. We're just using the word now steatotic liver disease. And if we say steatotic liver disease, that means less than 5% of fat in the liver. Okay? It can cover metabolic dysfunction-associated steatotic liver disease, or MASLD, and alcoholic liver disease. So fatty liver, you have a normal liver, then there will be accumulation of fat. There are two classifications. One can be alcoholic, so we call that metabolic alcoholic liver disease, or METAL-D, or a non-alcoholic liver disease, or MASLD. And the non-alcoholic fatty liver disease, NAFLD, that's just the old name, can be divided into metabolic associated steatotic liver, which is the benign one, the simple fatty liver, or if you have steatohepatitis. So again, non-alcoholic fatty liver disease was the old term. We need to know this because the GI might be using already the new terms now for our clinicians. Okay, the non-alcoholic steatohepatitis was NASH, which meant inflammation and leading to fibrosis. But now we call it metabolic dysfunction associated fatty liver disease, or MAFLD. If it's MAFLD, it can coexist with other like alcoholic disease. But if we use the term MASLD or metabolic dysfunction steatotic liver disease, we can divide it into the alcoholic metabolic, which is metal D, and the fatty liver alone, which is the MASLD. And that is, of course, the other one is the hepatitis. So MASH, that means your patient is hepatitis. These are the patients who have chance of having fibrosis. By the way, the new technologies now that they're doing is they're now looking for viscosity of the liver, but that's still in the process. Okay, so quantification, why do we need it? They say around the world it's 25 to 30%. But I was looking through some Nepal data. I'm not sure if this is, but this was in 2020, I think. So they said that Nepal has a lower fatty liver incidence, about 17 degrees. But since we have already a westernized diet, sedentary lifestyle, it might lead again to obesity and NAFLD in Asia. So again, this is mentioned earlier about the fatty liver disease. These are the ones that we have to watch for. Metabolic syndrome. If you're obese, high blood pressure, high triglyceride, high blood sugar, high cholesterol. So these are the people who need to check if they have that. And why? Because you have healthy, you have muscle D, then you have then the third is the MASH. Then it may lead to the fibrosis, then cirrhosis. But remember, this is reversible at the MASH level. Like this, when they had a resolution of NASH after lifestyle change. But if you have already F2, then they might give you medication. Okay, so again, this says if you're diabetic, if you have those who are advanced fibrosis, diabetes, and those have history of cirrhosis, and those with metabolic disease. Okay, so we need to know because it's reversible. So the methods, you know that, and we included the one is MR, but to make it equivalent to MR, they now made the ultrasound version. Okay, so the ultrasound version, we have this now. We have we have this from the different companies. And the one that I was using, as I said, was the Siemens one. And then if it is this UDFF, which is related to, comparable to MR-PDFF. And then other companies have now also shifted. I think there's also Samsung and GE who've started with giving the in percentage. So the other one is not in percentage, but this one is in percentage. So who refers to us? Gastroendocrinologists. Why do they come to us? They are known to have fatty liver in ultrasound. They have metabolic syndrome. They have a high SGPT. And they are thinking of cirrhosis. So, again, you can do no need for fasting if it's just fat. Okay? And we do hope that you're going to learn it and do it because it has now become very easy to do. and we might be able to help the patients before they go to liver transplant and before they go to cirrhosis and hepatocellular CA. So it's shorter time, it's easier to do, and but different vendors have different ways. So that's also another thing you have to understand. So greetings from the Ultrasound Society of the Philippines, and greetings from the Philippine College of Radiology, where Dr. Tejandra Karki was just last February. And this is our place, but this is as of 2022. A lot has changed since 2022. There's now going to be a new building there. And so just like technology, it's too fast, right? But we have to follow the technology. We have to learn always what's new. Thank you very much.